Alright, so in the previous video we talked a little bit about just some basic factors about blood flow, pressure and whatnot. We talked about the fact that there needs to be, in order for anything to flow throughout a cylindrical tube, there needs to be an actual, or I should say, like a fluid to flow through a tube. There needs to be a pressure gradient, which is basically a difference on one end of the tube versus the other. So basically, there has to be something that creates pressure because pressure drives flow. All right, and obviously in this situation, when we're talking about humans, that would be the heart. So the heart is the driving force of pressure that forces blood through arteries and then capillaries and then veins. But as blood flows throughout the vascular system, blood pressure and blood flow rates are going to kind of slow down a little bit, especially pressure. And there's a couple of reasons why. I mean, the biggest one is that we are getting further away from the heart, so basically what we're saying is we're getting further away from the source of pressure. The left ventricle, when we're talking about pumping blood through the systemic circulation. And then there's other factors that resist the flow of blood, like friction and the thickness of blood. We'll cover later in a little bit. But basically, when you put those factors together, getting further away from the heart, and then those opposing factors of flow, basically on the other end of the tube, we have a lower pressure. And basically on one end, we've got a high pressure, the other end, we've got a low pressure. And as a result, we can circulate blood. All right, we can actually circulate blood around the body. Now, obviously there are many vessels in the human body. So basically, in the previous video, I explained that that we create a pressure gradient. There's a pressure difference between the arterial system and the venous system of the body. And basically that difference allows for blood to flow through arteries and then through capillaries and then to veins and then eventually back to the right atrium of the heart, and then we just kind of start all over again. Okay, and basically when it comes to pressure itself, the pressure that drives flow, that essentially is blood pressure. All right, now by definition, blood pressure is the force that blood exerts against the walls of vessels. Okay, now this is a little bit different from when we talked about the cardiac cycle, because when we were covering the cardiac cycle, we talked about the relationship of volume and pressure. We said that under most circumstances, volume and pressure have an inverse relationship, whereas if one goes up, the other goes down. However, when it comes to pumping these fluids throughout our vascular system of the body, it's a little bit of a different scenario here. As volume rises, pressure also rises. Okay. As volume rises, pressure goes up as well. All right, so a key factor, not just in blood pressure but also in blood flow, is essentially the volume of the blood, the volume of within the cardiovascular system. So as our blood volume rises, blood pressure will rise as well. And I'll talk about some factors that promote that, but just for now, kind of keep that in mind. All right, I'll talk about factors that promote that in a little bit. So, but basically, under normal conditions, we would say that blood pressure is 120 over 80 millimeters of mercury. And remember that when we're dealing with blood pressure, your top number is systolic, and your bottom number is diastolic. Okay. And obviously these terms should sound familiar because when we cover the cardiac cycle, we said that systole was when the ventricles of the heart or the atria were contracting and they were ejecting blood out of themselves. And we said that diastole was a resting state, and then that the chambers that were in diastole were refilling. And, basically these numbers are reflecting the activities of the heart. So if you understand the concept of systolic, basically pumping, it should make sense then as to why this number is higher, why systole is a higher number, because, for a couple of reasons. A, because the heart itself, obviously, let's be more specific here, the left ventricle, when the left ventricle squeezes, when it contracts, all right, it is that alone is just creating an increase in pressure. All right, and that increase in pressure is driving a higher volume of blood into the vascular system. All right, so when that left ventricle is squeezing blood out of itself through throughout the aorta and then dispersing more blood throughout the arterial system, that is creating a higher pressure. All right, so that's why systolic in under normal conditions is going to be high, all right, or higher than diastolic. All right, so basically so it's a reflection of two things. The systolic pressure is essentially a reflection of two factors. The force at which the left ventricle is contracting and the volume of blood that is coming out. And a big player into that volume isn't just the volume coming out, but the volume that came back into the heart. Remember, we talked about preload, and basically, when you have an increased preload, an increase in the amount of blood in the either in the chambers of the heart, that causes them to stretch more. And when the chambers stretch more, that causes an increase in contractility, and you're going to pump more blood out. All right, and then obviously some factors, and we'll talk about some more factors that promote that. But basically, that's why systolic is higher because it's not just because of the force of contraction, but also the increase in volume in the vessels at this time, especially the arteries at this time. So then the question you should ask yourself then is, if diastolic or diastole is a measure of when the left ventricle is at rest, why is there even a number here in the first place? Why is there even a number there in the first place? The answer to that is because there's still an actual volume of blood. Okay, there's still blood in the vessels of the in the vessels of the body. It's just that basically when the left ventricle relaxes and it's kind of going back to its state of rest so it can refill with blood. Remember that arteries are they're very rubbery vessels. They have a lot of elastic tissue within them. And basically that's an important characteristic because remember, arteries have smaller lumens, all right, so they've got smaller openings that we're pumping blood through. And as a result, all right, since we're pumping blood through typically a more narrow vessel, on average, especially when we're talking about your distributing arteries like arterioles of the body, we need these vessels to be very rubbery. So when the left ventricle is in systole and it's basically dumping a higher volume of blood into the arterial system, that's going to cause the walls of the arteries to expand, all right? Because remember, an object that's elastic, when you apply pressure to it, it's going to stretch, all right? It's going to stretch. Now, when the left ventricle returns to a resting state, all right, that means that pressure that the left ventricle is putting against blood to drive it into the vascular system, that pressure is going down. And basically when that pressure or force is being reduced, when it's going down, that is going to cause the walls of the arteries to recoil, all right, or return back to their original shape. Because remember, that's how elastic objects work. When you apply pressure to them, they stretch, and then when you relieve the pressure, they return back to their original shape. That's what we refer to as elastic recoil. Now, that's an incredibly important characteristic for arteries to have. Because again, arteries have narrow lumens. They are having blood pumped into them with high velocity, high pressure blood is moving through them. All right, it's very important that the walls of arteries are elastic and that they stretch. All right, so basically, when the left ventricle returns to a resting state and the walls recoil, that's actually important because that helps promote blood flow while the left ventricle is taking a second to rest. All right, so basically this allows for constant blood flow all the time. When the left ventricle contracts and increases the volume of the arterial system, we're going to have, naturally, that's going to cause blood flow due to increased pressure. But then when that ventricle is taking a second to relax and refill, the arteries recoil back to their original shape or state. And then when the arteries recoil, that basically squeezes blood through. That will basically squeeze blood through them and cause blood to continue to flow. So this results in a fairly constant flow of blood. all right, whether the heart is contracting or resting. And that's why there's still a number here because there's still a volume of blood within these vessels exerting, putting force against the walls. All right, because remember, volume essentially, when we're talking about vessels, volume creates pressure. All right, it's just that there's a little less volume when the left ventricle relaxes. Okay, now we would say that 120/80 would be normal. This would be normal resting blood pressure. Um, Now, obviously, that's a very, very general number because this number can change a lot based on age, gender, body size, and whatnot. How in good a shape you are. I remember when I was about 19 and I was running cross country in college. My resting blood pressure was average about 104 over 64. Um, so basically, and I wasn't anywhere near dying. So basically, that's just a reflection of just a better heart, a bigger, stronger heart that worked as a more efficient pump. All right. So that's something to kind of keep in mind is that this is just an average number that people should kind of be operating within. And then hypertension is what we refer to as high blood pressure. All right, hyper means excessive, and tension, basically pressure. All right, and kind of your benchmark for hypertension is a systolic of 140, diastolic of 90. So we would just say 140 over 90. Pre-hypertension is kind of when you're leading up to that. That basically would be if you're kind of around 135, like 135 over 85, and then anything at 140 over 90 and higher, we would classify as hypertension. Now, hypertension can fall into two categories, what we refer to as primary and secondary hypertension. If we say someone has primary hypertension, that basically means that they have high blood pressure and for natural causes. Something is naturally causing their blood pressure to rise. Realistically, the exact cause of primary hypertension isn't well understood. I mean, obviously there are many complex changes to our anatomy and physiology as we age. That's typically when we start to see the effects of this when we get older. And probably one of the better understood contributing factors to this is the loss of elasticity in arteries as we age. This isn't something we can stop, but we can slow it down through regular exercise. But basically, the elastic fibers that are normally found in the walls of arteries of the body, the elastic fibers kind of start to cross-link or link together, and basically that causes these proteins to kind of tighten up, and then cause these elastic arteries to become more stiff as we age. Now, think about that for a second. That's gonna pose a problem because now we are having to pump the same volume of blood now through more stiff, narrow vessels. What's that going to do to blood pressure? Well, it's going to bring it up. All right. Well, since the arteries are losing their elasticity, they're not going to stretch as much. How are we going to basically kind of create a balance and create continuous blood flow? Well, the answer to that is the heart's basically going to have to work harder. The left ventricle, especially, is going to have to pump a lot harder to circulate the same volume of blood throughout the cardiovascular system. And that's going to cause the left ventricle to hypertrophy, get larger, and there's lots of chronic complications that come with that if you don't regulate the hypertension very well. But that's basically what's going to happen with primary hypertension. And that's one of the big reasons why blood pressure rises as we age is due to the stiffening of arteries, all right, amongst other reasons, but that's one of the more commonly talked about ones. Secondary hypertension, this is when someone develops high blood pressure as a cause of another, or it's a result of another problem. For example, if someone's a type 2 diabetic, so if someone's a type 2, I'm just going to abbreviate that, type 2 diabetic, and they have hypertension, I'm just going to abbreviate that as well, they've got high blood pressure as a result. So obviously the primary problem here is the diabetes. They've got high blood glucose levels, and typically when your blood glucose levels start to exceed their normal levels, that's also going to cause your blood pressure to rise. All right, because your blood's going to become a little more viscous. It'll increase the volume of blood a little bit, and the heart's going to work harder. It's a mess. But again, the primary problem is the type 2 diabetes, and the type 2 diabetes is causing the person to have high blood pressure. So that's the difference between primary versus secondary. Primary is a disease that's caused by natural means. Secondary is something else is causing it. Another example that I like to think of with that is Parkinson's disease. Parkinson's disease occurs when the substantia nigra of the midbrain starts to slowly degenerate. And if that happens, we really don't know what causes primary Parkinson's. I mean, there's a lot of theories out there, but the exact cause still isn't well explained. But basically, for some reason, in some people, that area of the brain slowly falls apart. And then you see dopamine levels go basically haywire. The dopamine levels get off, and then that causes the neuromuscular complications, the tremors, and as it gets worse, the shifted gait, trouble speaking, breathing, all that stuff. But that basically is primary Parkinson's, whereas secondary Parkinson's would be caused by some outside source damaging that area of the brain. If you had a stroke in that, if you had a stroke in that area, the brain became damaged, and you developed Parkinson's. Obviously, the primary problem is you had a stroke. Secondary problem, you had, the stroke. If you took on physical trauma in that area, the brain got damaged. The trauma would be the primary problem, and then the secondary result was you develop Parkinson's-like syndrome or symptoms or the disease itself. All right. Another common cause of hypertension is as we get older, our renal function goes down. And remember before I mentioned that that blood volume is a key contributing factor to blood pressure. All right, is a key contributing factor to blood pressure and flow. All right, and basically, if we have a greater or an increased volume, we're going to have an increased pressure. Right. Now, this is why the kidneys are the primary long-term regulators of blood pressure, because basically for example, if our blood pressure is getting high, the kidneys can pretty easily compensate for this by just increasing your urine output. Okay, increasing urine. I'm sorry, pardon the horrific handwriting there. By increasing urine output. That urine is primarily composed of water. So basically, if we have volume expansion, if we increase our volume and our blood pressure rises, under your kidneys, if they're healthy, what they're going to do is your kidneys are going to just eliminate excess water. Vice versa, if our blood pressure gets too low, your kidneys will retain water. And so the kidney can, most of the time on its own, but also with hormonal controls and regulation, the kidneys can, like I said, can exert a lot of control over blood pressure, essentially by controlling volume, by controlling water volume of the body. All right, which is a topic we're going to visit a lot more in depth later on when we talk about urinary physiology. All right, so that essentially is hypertension. Hypotension would be low blood pressure. All right, blood pressure that's getting too low. Typically, kind of the benchmark for this is 90 over 60 millimeters of mercury. Again, there are some people that have a blood pressure like this and function normally, or even a little lower than this. All right. Typically, hypotension gets to be a problem when blood pressure gets so low that perfusion rates are dropping big time. Because remember, if we have a decrease in blood pressure, if we have a significant decrease in blood pressure, that's going to decrease blood flow. All right, and if we have a drop in flow, that's going to cause a drop in perfusion. And remember that concept of perfusion. Remember, flow is kind of a reflection of cardiac output, how much blood is being put out of the heart on a minute-by-minute basis. And then whereas perfusion is more tissue-specific, perfusion is the amount of blood that is going into an organ or tissue that is basically a specific amount of blood that is essentially meeting the metabolic demands of that tissue. All right, so perfusion is just a little more specific. But basically, if blood pressure gets so low that we can't properly perfuse our organs with blood, then that's going to be problematic because then we're not delivering enough oxygen and nutrients, and simultaneously, we're not clearing enough metabolic waste. And you put those two together, and that's going to start causing the destruction of that organ. Now, how rapidly this onsets is going to determine how extreme the tissue damage or death is going to take place. If we have if our blood pressure completely bottoms out, well, you're going to start seeing organ failure pretty quickly. It could be within minutes, especially if you're thinking about an organ like the brain. Because the brain, even though it's one of the smaller organs of the body, the brain metabolically is an absolute hog. It requires so much, it just consumes so much energy, glucose, oxygen, and so on. And a big part of the energy consumption comes from your cerebral cortex. Obviously, globally, the brain burns a lot of fuel, but part of being a sentient, higher functioning creature is having a high functioning cerebral cortex, which creates consciousness and conscious interpretation and understanding of our environment, higher level thinking, intellectual processing. All right, lots of blood flow to the cortex. And basically, that's why if someone's blood pressure starts to drop really quickly, you're going to start seeing them slipping out of consciousness pretty quickly as well. All right, so that's something to kind of keep in mind is that as blood pressure starts to drop, you're going to see the person slowly slip out of consciousness. And then obviously, it's not just the brain that's affected by this, it's other organs as well, if your blood pressure remains low. Except the brain is really sensitive to this, again, just due to the high demand of neurons or the high metabolic demand of just that dense network of neurons in the brain. I mean, if the brain is completely deprived of oxygen, within 2 minutes, you can start seeing brain damage set in. And typically after about, depending on who you ask and what first aid CPR class you take, typically within 8 to 10 minutes, you can start seeing permanent brain damage set in if the brain is deprived of oxygen. All right, so again, and then the causes of hypotension vary. If there's a significant drop in volume, due to hemorrhaging, bleeding. There could be neurological in cause. If someone has a severe allergic reaction and they massively dump out a bunch of histamine and they lose a lot of fluids from the blood into tissues, that could cause a severe drop in blood pressure. Basically, what I'm saying here is I'm basically describing various examples of shock. Because shock is a general term to describe a significant decline in blood pressure. And shock is just essentially named for what causes it. It could be anaphylactic shock, which is an overload in histamine. Neurogenic shock, where neurologically you drop your blood pressure. For example, if you're pooping too hard or you're really stressed out, or it's really hot, and that causes stress, and then you have a little bit too intense of a vasovagal response, and which I'll explain later on, and probably in another video. But basically, if you stress yourself out and you respond a little too intensely, and your vagus nerve drops your blood pressure or your heart rate way too much, that could bring your blood pressure down. That would be neurogenic. Cardiogenic, if you have any problems with the heart that are lowering blood pressure, you get the picture here. Too significant of a drop in blood pressure, hypotension, will cause a lack of perfusion to your organs, and if you don't correct that, that's going to start causing organs to fail and die. All right. So remember that blood pressure changes as we. Oh, actually, before I move on to that, I forgot. I wanted to talk about one more thing before I moved on to the next thing. Clinically, when it comes to diagnosing high blood pressure, hypertension, how does this work? I mean, let's think about how this works for a second. So let's say you go in for a checkup, and you go in for a checkup, and now you go in, and you're on your way to the clinic, and some jerk off just cuts you off on the road. And if you're like me, you're going to sit there and yell and swear for a while. I kind of have some road rage problems. You're you're gonna sit there and curse and get mad. At least I would, which was a daily routine when I lived in the state of Minnesota because people are crazy drivers up there. Nice people, just crazy drivers. Haven't had to do that as much now that I live in Kentucky, which is kind of nice. But basically, let's say that happens and you go into the doctor's office and, well, what's your blood pressure going to be like? It's going to be high. All right. So if you're in a situation like that and the doctor measures your blood pressure, they're going to, a decent doc, even a, doctor, nurse, they're going to ask you, well, what's going on in your life? What happened? And you're just going to say, oh, some pinhead cut me off. Of course, pinhead would be a nice thing to say. I'd probably say something worse than that. But you'd say, some pinhead cut me off on the road. I had a stressful day. I had to run a bunch of errands before I showed up. I had to bring the kids to school. I mean, whatever the situation may be, you could have just walked into that doctor's appointment stressed out, and that's going to bring your blood pressure up higher than normal. That's normal. That should happen. Or if you've ever heard of what's called white coat syndrome, just basically seeing the white coat, seeing the doctor. I mean, because whenever you go to the doctor, a lot of times we always have in the back of our mind, what if they find something wrong? What if something's wrong? What if something's wrong? That can make you nervous, and that anxiety could crank up your blood pressure. So they're not just going to all of a sudden start medicating you, and at least they shouldn't, start treating you for hypertension right away. Typically, you need to get 2 to 3 consecutive readings of hypertension. So that's kind of something to keep in mind about diagnosing high blood pressure. And then what they'll do is they'll put you on the wrong medications or the wrong dosages, and then it's going to be miserable for a little while, and then they'll eventually kind of straighten it out because, like I said, hypertension is a complicated thing. That's why a lot of times, it's rare that you ever hear about somebody just get the exact medication, the exact dosage they need. Because, like I said, there could be many different causes of blood pressure. It could be as we age, as our renal function starts to go down. It could be we have a harder time handling water. It could be something related to the heart. It could be renin related. You name it. It's a complicated thing dealing with high blood pressure. So, but I just want to throw that in there real quick before I moved on. And remember that basically what we're looking at right here, we're basically looking at mean or average systolic pressure throughout the vascular system. But what you're essentially looking at here is you are looking at a pressure gradient. All right, you're looking at high and low. All right, and basically, like I said, this drives blood flow throughout the body. All right, which is a good thing. So basically, arteries, being that arteries are connected to the pump, they're connected to the source of pressure that drives blood into them, or throughout the cardiovascular system. All right, this pump is constantly increasing the volume very rapidly of arteries all the time. So as a result, arteries are going to have a higher pressure. And typically, the mean, like of your large arteries and your large branches off of the aorta, we would say that their mean arterial pressure is about 100 millimeters of mercury. All right, and then as we have these opposing, and then basically as arteries get smaller and disperse to more specific areas of the body, then basically what we've got, the pressure is going to drop to about 30 to 35 millimeters of mercury. We'll say 30 to 35 millimeters of mercury in our arterioles. All right. Again, because we're getting further away from the heart, and also because, what was I going to say? Because we're getting further away from the heart, and because of peripheral resistance, factors that are slowing down flow and pressure. All right. You think about it as well. And so let's say we got our heart rate here. We've got our heart here. We've got our aorta, and let's just say we've got. Again, this is just for the sake of discussion. We've got this vessel branching way out of here. So let's say this is your left subclavian. So basically, as blood is first sent out of the left ventricle into the aorta, all right. Obviously pressure is going to be highest in the aorta, where obviously that's the main artery that's connected to the source of pressure, and this is going to have the highest volume of blood in it as blood is coming right out of the left ventricle. And then as blood is going to basically work its way further down the arterial system, all right, as it's going to work its way further down the arterial system, and we have more branches, all right, as we increase the surface area or the cross-sectional area of the system, what's going to happen is all these smaller vessels are going to have a lower volume in them, all right. Therefore, that's going to create a lower pressure. All right, and plus, like I said, just in terms of distance, we're getting further away from the left ventricle of the heart. Thus, we're getting further away from the source of pressure. So that's why pressure is going to be a lot higher closer to the heart, because a greater volume. As we disperse that volume out further, or as we disperse these vessels out, as we get further away from the heart, less volume, lower pressure. All right. And then eventually what's going to happen is arterioles are going to basically form meta-arterioles and then capillary beds. All right. And I'm just going to, I don't feel like changing pen colors here, but basically then what's going to happen is with capillary beds, and I'm going to discuss this way more in depth in the video on capillary fluid dynamics, but typically on the arterial end of a capillary bed, the pressure is going to be 35, and then on the venous end, the pressure will be about 17 millimeters of mercury. All right. Again, these numbers are going to vary slightly depending on what book you're reading, but the concepts are still going to range true. All right. Now, so basically what's going to happen here is the volume is going to, obviously, what's going to happen as we disperse blood through the smaller vessels, basically that's gonna the decrease in volume in each individual capillary is going to reduce the pressure slightly. And then another reason why the pressure is going to drop as blood flows through capillaries. Remember, capillaries are porous. As we drive fluid out of capillaries and take oxygen and nutrients into tissues with it, that's going to cause a reduction in volume, thus causing pressure to drop. You're noticing the pattern here. All right. And then basically by the time blood gets into the venous system, I mean, volume is way down. Volume is way down, you idiot. Basically, pressure is way down because we've essentially gotten so far away from the left ventricle of the heart, and so many peripheral factors are resisting the flow of blood. That's just going to dramatically reduce the pressure and flow. All right, so that's something to kind of keep in mind, is that veins are very, very low pressure vessels. Another thing about veins too that tends to keep them at a low pressure is that veins have very large lumens. All right, they have very large openings, whereas arteries have much smaller lumens. All right, arteries tend to have thicker, more muscular walls, but veins have bigger lumens. So this bigger amount of space, that also creates a lower pressure. And therefore, we tend to store a lot of blood in veins, and that's why we say that veins tend to be the reservoirs for blood, because blood flows through them a lot more slowly, so we tend to keep a lot more blood in our venous system. So, at a resting state, upwards of 60% of your total blood volume is found just in your venous system, okay? So almost a little over half of your blood is just in your veins alone, all right? And so that's kind of something to think about. So we've got this pressure gradient here, and honestly, I just explained all that. I don't feel like going into that again. But basically, now what we have to think about then is, obviously we have to keep this going, right? We have to keep this going. It's nice that arteries are high pressure vessels, but because the veins are so far away from the heart, even though most of the blood in our body is in our veins, we've had to deal with all these peripheral factors that oppose flow, and we've gotten so far away from the left ventricle that pressure and flow are really low in veins. So as a result, veins rely on a few more elaborate mechanisms to get blood back, essentially back to the right atrium of the heart, so we can circulate blood. And one of those factors is just gravity. All right, gravity. Think about this for a second. If we take a look at a person, this is about as elaborate as I care to get with this artwork here, but if we take a look at a person and we're looking at their heart, okay, and I don't know why the heart's above the shoulders here, but you get the picture. Um, but basically, you have to. It's very easy for blood from the head and neck to drain, into the superior vena cava of the heart because down through the jugular veins and back to the heart. Because gravity is a force that pulls objects towards something else. In with the situation of us, while we're on Earth, gravity is pulling us down towards the Earth. That's what keeps us on the ground. All right. So basically, any blood that is coming that is above the heart is just going to is going to very easily return to the heart just because of that. But however, most blood of the human body has to go back up. Has to go back up to the heart. And obviously, we're working against gravity here. Gravity's not working in our favor. That's another reason why blood tends to remain in veins because most of our veins, gravity has an effect on blood. So basically, there's a few different mechanisms of returning blood back to the heart, especially with these veins below. First off, remember that veins have valves. Okay, they've got valves, and remember the purpose of a valve in anything is to promote one-way flow by preventing backflow. So when a valve is closed, fluid should not be going back through it. And when a valve opens, fluid should be moving one direction. Okay, so basically, typically when you're thinking about, you're going to hear this again when we get to the lymphatic system. But basically, when a vascular wall stretches a little bit, if it stretches enough, the smooth muscle in the walls of those veins could be responsive enough. Basically, if they're stretched to a certain capacity, that could cause a slight contraction of the veins and drive some blood back up towards the heart. All right, or just by breathing. Remember, when we breathe, when we breathe, our diaphragm, when our diaphragm contracts, it flattens out. And then what that does is that increases the dimensions of the thoracic cage, especially at the base of the thorax. And as that diaphragm basically flattens out, it gets bigger. That pushes down against your abdominal organs, and then that could squeeze some of those veins, and then squeeze blood. Promote it to circulate around. So that's essentially what the respiratory pump is. The muscle pump here. All right, picture this for a second. The muscle pump. So basically, a lot of these vessels are located in between muscles. All right, and remember the word contract. The word contract. The word contract means to shorten. And when muscles contract, they shorten. They kind of get chunkier. They ball up. And then picture these muscles squeezing veins and pumping more blood back towards the right atrium of the heart. Now, let's think about that in terms of exercise for a second. Because when you're exercising and you're contracting your muscles, especially more rhythmically, when you're contracting your muscles with more force, you are squeezing those veins a lot harder, and you're circulating more blood back to the heart. Now, that is going to create an increase in filling. All right, that's going to create an increase in filling of the right atrium. Therefore, that means that's more blood that's coming into the heart, and that's more blood that's going to be pumped out through the left ventricle. All right, so basically that higher volume coming back into the heart is going to cause an increase in cardiac output. Remember, increase in preload, increase in contractility, lower end systolic volume, all that fun stuff. All right, now also when we exercise, one of the ways that we get a lot of that blood out of our veins, aside from the muscle pump, is we do so neurologically. When we exercise, we increase our sympathetic outflow to veins. And remember, blood vessels are only innervated by sympathetic nerves. This is one of the few instances where you don't hear about dual innervation with the autonomic nervous system. However, if we increase our sympathetic outflow, basically the amount of SNS output to these veins, that's going to cause the muscle of the media to contract. And as basically the veins contract or they tighten up, think of that as essentially just squeezing a tube of toothpaste. You're going to squeeze more blood out of veins, and back toward the heart. Couple that with the muscle pump, and we have an increase in venous return to the heart, and that's going to cause an increase in cardiac output and allow you to maintain, deliver more oxygen and nutrients and grab more waste products out of your muscles. All right. So those are essentially mechanisms of venous return, and remember that we need to utilize these because of what was I going to say? Because of gravity and the low pressure environment. Now, another thing, let's think about this for a second. Let's say you work in a job where you stand for long periods of time, where you just stand for long periods of time. So basically, if you stand for long periods of time, you're not utilizing that muscle pump. Okay, you're not utilizing that muscle pump. And because of gravity, most of that blood is going to want to pool down in your dependent areas of the body. The dependent regions of your body are the areas that gravity takes the highest toll on or has the greatest effect on, which is the lower parts of your body, your feet and so on. That's why essentially if you stand for long periods of time, your feet are going to look a little swollen because basically what's going to happen is you are going to essentially you're going to return less blood back up to the heart. And then what's going to happen is, so let's say we got an artery here, a vein here, and we've got some capillaries. Now, if you're not returning as much blood back to the heart, that's going to create a little bit more pressure or volume and pressure in the venous system, and basically it's going to be a little harder to circulate blood through capillaries, and it's going to move through here a little more slowly because we have a decrease in our pressure gradient. All right, so basically that's going to cause some more fluids to essentially leak out of your capillaries and into the tissue spaces of the lower parts of your body, and that's going to basically decrease your blood volume just a little bit. Now, that's why if you stand for long periods of time and then all of a sudden you start walking around, you might get a little lightheaded because your blood volume just dropped a little bit. And then as you start walking around and then you get that muscle pump going and you're getting a little less blood back to the heart, you'll recover from this quickly, but that's why you get a little lightheaded after standing for long periods of time, and then you start moving around. It doesn't always happen, but it can happen. All right, so now what we'll do next is, in the next video, I'll talk about laminar versus turbulent blood flow, and then we'll talk about factors that oppose blood flow.